My grandmother always used to tell me growing up, Damien, if you don't listen, you'll feel. And I feel like this is one of those moments that we didn't listen. And so now, unfortunately, we're feeling in a very horrible way.
Good evening. Thank you for taking time out of your lives for a period to listen, learn, and have a dialogue about what we have grown to understand as an epidemic in our nation and, more importantly, our communities. We decided to show this film in its entirety because it represents several ideas that are in response to a long period of dealing with the opioid crisis. Some of the ideas and strategies may be new to you and may feel difficult to accept. We have assembled 4 people and invited many others this evening to discuss some of the things that are shown in the film and are open to other ideas and experiences, all in the name of saving lives and working towards an end to this crisis. As many of you know, a strong focus of our work at the Wayside Multi-Service Center is through community-based and regional prevention coalitions such as the Watertown Youth Coalition, the Belmont Wellness Coalition, and Substance Abuse Prevention Collaborative. Primary prevention, as we know it, aims to address substance use upstream. That's jargon for early on before a problem develops. And we will continue this work along with our many partners in the region, of which many of you are here. We are eager to help you and your friends and family to understand better how to prevent substance use. Please join our efforts or ones in your community to be part of furthering that work. We also know it is vital to address substance misuse to include intervention, treatment, and recovery. WGBH's Nova has created this documentary, Addiction, and we hope you will find some information that can be helpful today and going forward. Please remember to advocate for your loved ones that may be struggling with the disease of addiction. They are now and always have been worthy of love, support, and life. I would like to introduce now Sarah Holt. She is the writer, director, and producer of this documentary you have come to see tonight.
So thank you for being here, and thank you to the Wayside Youth Family Support Network. I really appreciate you making this the screening possible. We've been going across the country trying to show the film. Just to give you just a quick introduction about the film, a lot of the thinking in this film came out of my own journey. Like nearly half of all Americans, I had loved ones struggling with addiction. I wanted answers. I wanted to know, what do drugs do to the brain? Why do people struggling with addiction? How come it's so hard to stop? Is there effective treatment? I would call up treatment centers and be amazed at the prices I would get, $15,000, $20,000, $30,000. And there was no data for whether any of this treatment was effective. So I set out to try to find answers. I hope tonight this film will leave you with important information. Many people kept saying to me, oh, it must be so depressing working on a film about addiction. And in fact, it wasn't. I met amazing people on the front lines making a difference. You're going to hear from some of them tonight on the panel. And it really gave me hope that, this is not a hopeless diagnosis. We have effective treatments that are emerging. And it was clear to me there's so many things we could be doing now to stop preventable deaths. So I hope you'll enjoy the film tonight and then the panel. Thank you.
A devastating epidemic.
We just didn't know what to do. We just felt powerless. A parent's worst nightmare, to find my kid not breathing.
He was always very good at telling us, Mom and Dad, everything's gonna be fine. But it wasn't.
Addiction is ruining lives and ending them too soon.
Overdose is the #1 cause of death for people under 50.
We are racing against time. We have the equivalent of a Boeing 737 crashing every single day.
But what causes addiction?
Individuals struggling with addiction are actually battling millions of years of evolution because our brains are exquisitely evolved to seek rewards.
It's those cravings, the inability to stop.
A dangerous cocktail of biology and medicine, made deadlier by a drug 100 times more potent than morphine.
fentanyl is super toxic. So you get a batch that comes on the street that's a little bit hot, and on those days, it's like bam, somebody's going down, bam, somebody's going down, bam.
But can new treatments offer hope?
We have extremely effective medications that are life-saving. This is a very treatable illness.
The solution to this is for us to embrace addiction as a disease, to bring it within the house of medicine.
People recover from addiction. Nobody is unreclaimable. The only thing that you can't recover from is death.
Addiction on Nova.
Okay, I've seen this film now a couple of times, and I think I should probably set my clock to see it every 6 months or so, really remind me of some of the things that are brought up in it. To no further ado, I'd like to introduce Tali Schiller.
All right, I would like to invite our panelists to come up to the table, and as you take your seats, I will be reading out your bios so that everybody knows who our illustrious panelists are. All right. Okay, so here, sitting closest to me is Peter Arasian. He is a lifelong Watertown resident and graduate of Watertown High School. He is also the owner of Patriot Chimney and Masonry and the co-founder of Watertown Overcoming Addiction, as well as a member and advocate of the local recovery community. So thank you so much, Peter, for joining us. Then sitting next, we've got Dr. Laura Kehoe, who's the medical director of the Substance Use Disorder Bridge Clinic at MGH, which is a low-barrier transitional clinic, which is a component of MGH's Substance Use Disorder Initiative. She has cared for patients in primary care, inpatient, residential, and outpatient addiction treatment settings, and as a medical director at a Boston area methadone maintenance treatment program. She is also an assistant professor of medicine at Harvard Medical, and teaches locally, regionally, and nationally about addiction. She, of course, was featured in Nova's PBS documentary and is also a Watertown resident. So thank you very much, Dr. Kehoe. Next up, we've got Dr. Damian Archer. He is a family medicine physician and the chief medical officer at North Shore Community Health Center in Salem. He has been part of the medication for addiction treatment team at his health center since 2014, and for the last 3 years has served as the program director. He has a passion for teaching medical students, practicing integrated primary care-based addiction treatment, and developing diverse and inclusive learning and working environments. So thank you very much, Dr. Archer. And then last but not least, we've got Dr. Dara Ahrens, thank you very much, who is a primary care doctor providing holistic, comprehensive care at the Charles River Community Health Center in Brighton and Waltham. She is particularly interested in prevention for all, including lifestyle choices that lead to positive and enduring change. Okay, my first question is for Pete, since you're right next to me. What do you think are the most important things to look out for when we think someone may be showing the first signs of addiction? And please use the mic. Thank you. Yeah, but it's a big room.
I mean, first signs, that's tough to say. I mean, starts different for everyone. You know, you got to know your kid. If that's what we're talking about is someone young, middle school, high school, just pulling back from the family. Not knowing who their friends are, not knowing exactly what they're into or what they're doing. Asking for cash, as Woody just pointed out. You know, but it like I said, it's different for every kid, and really keeping an open dialogue with any young people in your house or young people in your life is really the most important. It's not a time to be sheltering kids. They know a lot more than I did. They know a lot more than my father did back in the day when we were adolescents. So the time for sheltering them is long past, and really just trying to be open and honest with them is will help you go a long way with that.
Thank you. Moving on, Dr. Kehoe. So we touched on supervised injection facilities in the documentary. I was wondering, many people feel that supervised injection facilities, also known as safe consumption sites, encourage active drug use and will fuel the epidemic. And I know this is a conversation we're having here in Massachusetts as well. So what can you share about this area that we're exploring in Massachusetts? Yeah.
So yes, so as was, I think, beautifully highlighted in the movie, supervised consumption sites or safe injection facilities, there's a minor change, but we'll just use the term supervised consumption sites, are actually part of the continuum of addiction treatment. And that's one of the gaping holes that I personally feel we have in Massachusetts. So harm reduction, going back to kind of define what it is in general, is literally what the words mean. It's reducing the negative consequences of whatever illness or issue is going on. And in this case, it's for substance use disorder. So when we think about it, in everybody in this room, I would assume, knows about Narcan and has either been trained in it or is known about it or is interested in learning about it. And that's the one harm reduction intervention that I think people feel pretty comfortable with. It's not quite as controversial now, and we've really kind of taken the lead in Massachusetts with that. Supervised consumption sites, I think the idea that it will enable people to use drugs is because it's a deep misunderstanding of what harm reduction is. So when we think of the continuum, we go from reducing negative consequences all the way to pure abstinence, but it doesn't happen overnight. Not everybody enters that abstinence for any illness. And so many people, especially the data that we have for supervised consumption sites, is that it doesn't increase drug use, believe it or not. It doesn't increase kind of littering or exposure around the area of supervised consumption sites. And what we do know is that it increases the chance of people coming in feeling safe and asking for help and actually being brought along into the system of care that we have, whether it's keeping them safe at that point and decreasing their risk of overdosing, of decreasing their risk of a severe infection to themselves or to others, and getting them into care. So here, one thing that Insight didn't show is that upstairs on the second floor, there's actually treatment there. So that's a really important piece to really highlight, that not everybody is coming in for the same reason, and every time we touch base with someone who's actively using, it's an opportunity to talk to them about their goals of care, whether it's keeping them safe at that moment or helping them to navigate the addiction treatment system, which is very, very complex and not welcoming to people who are using drugs. So that's a long answer to your question, which is the data shows it does not increase drug use, and the majority of people who are accessing safe consumption sites or supervised consumption sites are people who have been using up to about 16 years of active injection drug use. And so there's also this notion that it will bring a lot of young people who will start initiating, and the data for countries that have had this have not shown that. So it's a tool to target people who are actively struggling to help keep them safe and bring them in along the trajectory. But it is not a focus of abstinence. Questions about that? Because I would assume there are a lot of questions and concerns about that. Happy to answer.
Would they go home and use at night by themselves?
Yeah,
and the
so
likelihood of that happening is probably great.
Yes, the question is, it's a day program. Yes, ideally there would be 24 hours for, just as there is for 24-hour care in an emergency room. People can go in with any medical crisis, any condition, to an emergency room at any time. In this setup here at Insight, it is during the day, but you're right, in the evening, what then? And so that's speaking to other issues, housing, safe places for people to go. But the idea also is we do a lot of this in any system that we're seeing, is talking to people about how to keep themselves safe, really bringing in families and helping them to know about how to keep their loved ones safe, not locking doors, having Narcan, making sure that people are comfortable if they're struggling, that they can tell someone, I'm actually using, can you check on me, et cetera. And that's stuff that's very hard for people to do because it's attached to illegal drug use, and people struggle with that notion. But yeah, it's not perfect, but it's a very important tool to have.
My question for Dr. Archer is, so a topic that we didn't really touch on in this addiction documentary because they only had 50 minutes, but something that I'd really like to delve into right now is, what are your thoughts about what we've learned about racial bias and its impact on the opioid epidemic?
I think it actually was addressed in the documentary, just not very explicitly.
Mm-hmm.
There were 3 times that I sort of saw that kind of come through. First was with Casey and Casey's father, Ken. Why did Ken move his children to the suburbs and to private schools? Because his brothers suffered from addiction and disease and the disease in an era where it was neglected, it was criminalized and stigmatized.
Mm-hmm.
And I think that, as was said by the scientist who talked about how and showed us how dopamine affects the diseased brain and the normal brain, I think it was a very stark sort of way to see how racial bias in the early stages, when this disease was contained to the inner cities, when we didn't take the opportunity to see the people suffering from addiction in that way as our brothers and sisters, left us with now what is a hugely horrible epidemic, which hasn't even peaked yet and is twice the volume of deaths that we saw in the HIV epidemic. And that, to me, is just mind-blowing. But it also shows where when we miss opportunities to see each other as hearts beating and not the color of skin that we're in or the places that we live, and recognize that disease is disease. It doesn't care who it affects. And when we see early signs of it popping up no matter where it does, to take a moment and take stock and say, you know, this will inevitably affect me somehow, potentially, and use that as a learning moment. My grandmother always used to tell me growing up, Damien, if you don't listen, you'll feel. And I feel like this is one of those moments that we didn't listen, and so now, unfortunately, we're feeling in a very horrible way.
Thank you. All right, Dr. Ahrens, how should primary care providers manage acute and chronic pain in the outpatient setting to avoid contributing to the problem?
It's a good question, and I think that the people in the movie, the patients who shared their stories, did a nice job of showing us the ways in which we as doctors really failed people, and in terms of prescribing medications and not really following through and trying to address the underlying issue that people came in for. And so the important thing is figuring out, you know, what is the underlying reason that somebody's having pain, and how do we address that? And in most instances, narcotics are really not appropriate management for pain. And so finding other modalities, treating with non-narcotic pain medications, and then integrating other modalities. So for example, at our health center, we're lucky enough to have a provider who provides acupuncture treatments for our patients. And we know that evidence shows that providers who provide acupuncture are less likely to prescribe narcotics for their patients. We have integrative behavioral health because we know that addressing mental behavioral health issues such as anxiety, depression, people who come to us with history of trauma, as was mentioned in the film as well, are just going to respond differently to pain, and we need to be able to address all of that to be able to address their pain. Making sure if we are prescribing narcotics for short-term issues that we are doing so with very short-term prescriptions and having patients follow up more frequently so we can assess how they're doing, whether we're addressing their pain appropriately, and whether we're seeing any signs of substance use disorder or dependence. And working as well with our colleagues and our specialists together to collaborate to be able to make sure that we're addressing patients' issues.
Thank you. All right, I've got a audience question, and this is open to the panel and also to our front row experts. Is there a consensus as to how/when to introduce these risks and treatments within school settings? The documentary noted that the vast majority of people suffering from addiction started using before the age of 21.
Right now, there's not a standardized curriculum across schools, but they're working very hard on doing that. We know we start too late, and some of the data has shown starting in elementary schools, not necessarily talking concretely about drugs, but empowering kids to resist peer pressure, kind of looking and screening for anxiety, ADHD, depression, other risk factors, and talking in, if pediatricians and schools are in close connection, pediatricians doing a really good job screening family history who are at risk, 50% of people's predisposition. If they're exposed to an addictive substance is genetics, as they talked about, and adverse childhood events. So earlier, and how we're going to do that is actively being worked on.
I would just add that, so we're in a great position as primary care providers because we know patients and their families. We're taking care of the entire family. So not only is the child our patient, but the parents are too. So we have a sense of those social settings and what might be going on at home. And then we are screening children as they get older. We screen them more age appropriately with certain tools that help us identify issues. And then also just counseling parents and, things that we know, for example, that the younger a child is to start experimenting with drugs, the more likely they are to be at risk of developing a substance use disorder. So really knowing the families and being able to counsel about those things.
I just want to add one thing to this too, because it becomes very sensitive when we talk about introducing this concept to children, because we're very protective of them and we believe in the innocence of childhood. But that can very easily be taken away from us if we don't do as much as we can to intervene and prevent problems. And I feel what I think helps people to get around that in terms of being okay with earlier intervention is to move away from, trying to be the person at the end of the disease saying, why me, to saying, why not me? Why not my child? Because when you don't take the moment to put yourself in that position of considering that your child is at risk, if they're not in your care 100% of the time, you're going to miss an opportunity again. That not listening to what's happening in the community and feeling like your child is separate from everyone else.
And, just to springboard off of that, one thing that I see a lot, and I don't take care of children, but taking care of adults who have children, and the inclination is to cover up. There's so much stigma about this illness, unlike my other adult patients who maybe have a cancer diagnosis or diabetes or heart disease, where those are also very heritable illnesses, where they talk actively about that and let their children know about their potential risk factors. So it goes back to also really empowering people who are struggling with addiction, if they have children, to feel comfortable talking about that. And I think we really need to do a much better job. That's part of our whole anti-stigma campaign, but also empowering people. And it normalizes it for the children too, this generation that's coming up, and a very critically important piece.
Thank you. Yes, Laura?
I'm asked to add a piece. As preventionists, we really believe in having youth working with us, and families and parents and schools and the community, and this is representative of so many people here that work together on a regular basis to try to prevent addiction from happening for some people. We also strongly believe in looking at root causes, underlying root causes, some of which are underlying mental health issues or concerns, bullying, racism, which is now looked at also as trauma, the effects of trauma, I had some other things, gender and sexual identity. So you really have to look at those things too, as many people have mentioned here. We do a lot of work through the coalitions. You're always welcome to join us. Yeah, we do a lot of campaigns about really focusing on parents learning how to talk with their kids, build a foundation early that helps, rather than trying to have these conversations for the first time when they're a junior in high school. You must start early, and just care about them and have conversations, so that when you have to have the difficult conversations, you can have them, and they're going to be able to be connected with you. There's more. Woody has one.
Can we stay on this for a sec?
Yeah.
Okay.
You've got something to say?
Hi, Woody from Right Turn. You know, one thing I think that we've noticed at Right Turn through intake, and one thing that we've known for a long time is that the first exposure to substances was the national average is at the age of 14, but we've seen that through the availability, through the internet, through many opportunities, that the age of first exposure is kind of dropped back to the age of 12. And I'm seeing that a lot. We're licensed by DPH for 18 and over, and we're seeing a lot of young people talk about first exposure around the age of 12, primarily cannabis, alcohol, but also getting into mom and dad's medicine cabinet, right? Just a point.
All right. Thank you very much, everybody. So if you have questions, please raise them up so that Stephanie can grab them from you. And if you don't have questions, I have plenty to ask the panel, so don't worry about it. Here is one audience question. If taken in excess, can Suboxone be addictive?
If this is somebody who has an opioid use disorder, no, capital N-O. So the way this medication works is going back to, I thought the film did a really great job of it. When people are using opioids, they're using a high level of an opioid. An opioid is an umbrella term. It includes fentanyl, the most potent that we have, heroin, oxycodone, methadone, et cetera. Those are a high level that attaches to those receptors that they showed in the brain and can keep going up and up. The more you take, you get more opioid effect until you can actually stop your breathing, stop your heart, and overdose and die in the worst case scenario. Suboxone is what's called a partial opioid agonist. So when we give it to people who are physically dependent on opioids, it also binds to that same receptor, but in a much less perfect way, a partial way, and has a much weaker opioid effect at that receptor. The other key is it levels out. After a certain dose, it flattens out. So you could take 20, 30 more films or tabs of Suboxone and you will never get higher than that maximum dose of 32 milligrams. You don't need to know that, but that level. So that's one of the most important things in terms of this crisis, why we're so aggressive about encouraging people to get onto it, is because even if people are at that stage where they're still struggling with the natural history of this illness, they're ambivalent, they're not sure if they want to stop, they're not quite ready. If they're engaging in care and they're taking the Suboxone, even if they use opioids on top of it, that receptor is partially blocked. And if they use, every day they use, that opioid can't get into that receptor. It's going to kind of kick it away. And so we encourage people, every day you can get that in your body, you're keeping yourself safe, even if you're struggling with using. So as a pure harm reduction, overdose prevention key, that medication is helpful. And that speaks to people will say, well, I took it and I was using it. People are misusing it, they're abusing it. It actually, that's the natural history of this illness. The key is keep them engaged, see how we can do to get them on it, and you can't overdose on it if you have an opioid use disorder. So hopefully that's a takeaway from that, and it's coming in an injectable form as well to help people keep that level up, keeping them feeling normal so that they can have motivation to engage in other things as well.
Thank you.
Yeah, I was just going to... Laura and I have debated this a long time, and I've come around a long way on it. But I understand not, being able to get high, but it is still an addictive substance because I've come off it myself, and it was just as bad as anything else I ever came off of. And like I started this, I've come around on this, like, way around. And my thing is, do we have enough research and time into this where we know, and I know every case is different, but do we know where this sweet spot is where we can start to get people off of it, or is the plan to just allow the pharmaceutical companies to become rich off of the cure that they started? That's where the disconnect for me comes, and it eats at me. I'm all for keeping people alive, but just knowing that they started this and now they're supposedly curing it, it just doesn't sit well with
and
me.
that's totally valid, and I think a lot of people struggle with that. I mean, the pharmaceutical company got us into this, right, with vast overprescribing of opioids, and now we're pushing another opioid, so I get that. But we have robust data, and I think even stepping back, there's a difference between physical dependence and addiction, and I just want to highlight that because I think that is important for us to understand. Addiction are the behavioral manifestations that they showed us. So they showed us the addicted brain, and then people doing compulsively using a substance regardless of all these negative consequences. So that's reflective of these brain changes that have occurred that kind of rewire the brain, so people only can do that, like that mouse. Physical dependence, people who are not addicted, so anybody here who has high blood pressure and is on blood pressure medicine is physically dependent on that blood pressure medicine. If we take it away from you, your blood pressure will skyrocket. You could potentially have a stroke, but you wouldn't say that person's addicted to it. They're not compulsively taking it. They're taking it as prescribed, and their blood pressure's controlled, and they're engaging in life, et cetera. But they are still dependent, physically dependent. When people are engaged in care and on methadone or Suboxone, both opioids, and they're doing well, by definition, they do not meet criteria. We have strict criteria for addiction because those behavioral negative consequences, compulsively using, not being able to take care of their kids, homeless, not working because they're seeking out this drug, is gone. So they are only physically dependent. So to circle back, yes, you're physically dependent still, but you're alive, you're engaged in care, you're in treatment. And so the question is, why is that a problem? So that's the thing we talk about a lot. And so the problem is because the pharmaceutical concern, I totally understand a lot of people struggle with that. But the data shows that there's a 50 to 80% decrease in mortality rate if people are on this. And we have that data. We have decades of data showing that. Even before we got it in the United States, we were using it in Europe. France got a hold of their crisis with an 80% reduction in death with just buprenorphine.
And I mean, we've been going back and forth on this for a long time. But, a 12-step fellowship saved my life. Mm-hmm. So, that's the only problem I have with the video is that, they kind of like throws that to the side, like that doesn't work anymore. And I see it work every day. Still involved. So I just had to, say that. I mean, 12-step fellowship works. I'm proof of it. I know thousands of other people who are proof of it. So I'm all for keeping people alive. I know that I was helpless, I was hopeless, and I don't use anymore, and I was on a Suboxone clinic, like the picture they paint there where it's, everyone's talking about their feelings and all that stuff. That's not how they all are. Every addict is a con man, a con woman, and I know that the system is taken advantage of in some aspects. So like I had told you at the beginning, this is completely different. I'm for it. I just want to know if there is an end game anywhere. If we're gonna have people on it forever, or if we're going to try and get them back to, just off of everything, with treatment, with therapy, with all the things that they'll be able to do, getting back into a job. When is it okay to wean them down?
Sure. I love that Pete is bringing this up because this is a real conversation that I have with patients all the time. In fact, I can't tell you the last time I had a patient start on Suboxone that didn't say to me, I want to be off of this medication at some point. And I've learned now that the discussion isn't really about whether the medication works or it doesn't, and numbers and data and all of those things are less important to the patients that I treat than the trust that I'm able to build with them. And the first thing that I have to admit is, there was a lot of harm done to everyone with the opioid crisis and how pharmaceutical companies sort of, misrepresented the data and the information, convinced the medical profession that it was safe to treat patients with chronic pain for non-cancer pain reasons or terminal illness reasons. And we learned a huge lesson, but it was a huge, deadly mistake. So I think the first thing that we have to admit is everyone was wronged by this crisis. Everyone. Doctors were wrong, patients were wronged, society's trust in the medical system has been wronged. I think it's going to take a lot of work for pharmaceutical companies to lean in and take responsibility for their part in causing this crisis in order for people to really feel like the medications that do work, that I know work, and it's not about belief or faith or feelings, this is real, before people can have that trust in their physicians again. And that's going to take a lot of work. And there are going to be a lot of people that feel the same way that Pete feels and also be survivors of this disease without medicine. That is possible, but it's not something that I can recommend to all of my patients because not everybody is going to do that. To use another example, because I know we have a lot of non-medical folk in the audience, I have had patients who are hypertensive. And they were also hypertensive because they were overweight, they weren't eating right, they had a lot of stress in their life, and we start them on a hypertensive medication. And until they quit their job and move to a different part of town, and all these things that help to correct the things that cause them to be hypertensive in the first place are fixed, they can't really do without it. But it is possible. Not for everyone, but for some people it is. And that's the way that I think the discussion around, or that's the way that I have the discussion around medication for addiction treatment with my patients. There are some of you that will be able to come off the medication and may be able to not relapse again. That's unlikely given the type of disease that opioid use disorder is. It's defined by relapse. We didn't talk about that in the film, but it's a part of the definition of opioid use disorder. You have repeated exposure with negative consequences and eventual relapse. Now, some people could go the rest of their life without a relapse, and I hope that is the case, but it is potentially unsafe. And we've seen where patients who go into abstinence programs without all of those things being corrected in their life and exposures, when they relapse, they die because they've lost tolerance and they throw themselves back into one more night, one more time. And they're more vulnerable then than when they were using on a consistent basis. That's what keeps me up at night and scares me about abstinence programs. It's not that they don't work for some people, it's that if you do it and you don't do it for the rest of your life, that one night that you have a weakness could be your last night.
Thank you. I'd like to move, so I have a couple of questions asking about this link between Big Pharma and the opioid crisis. So I was wondering if somebody would like to provide a history of what ties those two things together.
Yeah, I think we've kind of the bullet is that way back in the 90s, there was this real push that we treat pain as the fifth vital sign, that we were not compassionate, we were not empathic, we were not holistic physicians if we didn't do that. And at that same time, these were patients with or without cancer pain. We had these medications that were really marketed as very effective. And we found, as we all are here and was highlighted, that with a vast overprescribing of these pain medications, it wasn't so much that patients with pain were getting addicted, and I think that's a take-home for today. They highlighted some patients with pain, but that by having all these medications in the community, in patients' family medicine cabinets, it increased the pool of those pills for people who did not have pain to start experimenting with it or taking it, and then this crisis stepped up. So it's in the under 10% of people with pain who are prescribed pain who become addicted, but it's the exposure to these pain medications for non-prescribed pain reasons that people get addicted. And that escalated, and then we had these 3 waves. We noticed that people were dying from prescription opioids, and then there were all of these really aggressive prescription drug monitoring program, misuse deterrent medications, a really wide expansive education of providers, of communities to decrease the prescribing. It decreased, everybody got excited, and then for every death that was saved from prescription opioids, we saw this steep and scary incline of heroin overdose deaths. And that was, again, just working on the supply side and not looking at this pool of people who are addicted, trying to figure out how to access a very, very insufficient treatment program or system, that all these people, the natural history is often to progress to something that's very accessible, cheaper, readily available heroin. And then now the third wave of the crisis is fentanyl, which is 50 to 100 times more potent. It's been called a poisoning crisis, where we're seeing now heroin. I can't remember the last time I saw heroin on a toxicology screen. It's really all fentanyl. And it's really not even just fentanyl. This is really a multi-drug crisis right now, that most patients are either getting fentanyl or other substances that are laced with fentanyl, or they're struggling, they're deathly afraid of fentanyl because they know how lethal it is. They still have this illness of addiction. Other drugs are available, so they're switching to that. So we're seeing multiple substances. And that is reflective of what's out there, but also our treatment programs are kicking people out of care if they're still struggling with drug use. And so that speaks to your point about people being con man. This is an illness of isolation and deep shame, and the medical community has not been welcoming, and treatment community. So it's not surprising that patients would keep this hidden from us and try to con us when they think they're going to be kicked out of care if they tell us I'm struggling with using, because that's been what our traditional treatment model has been. And that's why these low threshold, welcoming environments are how people gain trust and come in, and we can work with them. So again, a long-winded answer to your question, but there are things that I think are important to highlight.
I think it's good. It's important for context. You have anything to add?
Just that it's all so evolving. I mean, I just think about the way I was counseled about it in residency and how much it's changed the language and how we think about our patients and, think about it as a disease. We're just in the process of understanding it still. And so, hopefully even moving forward, there will be a better answer to these questions about should patients be on these medications interminably, or, what is the balance? And then the only other thing I just wanted to say too, Pete, about, what you were saying is that it also points to how there's no cookie cutter answer for any one patient, and that you have to work with the patient in front of you and determine what makes the most sense. And that's sort of the art of being a medical provider, is figuring out what's going to work for the patient in front of you.
What more can be done to support people after they leave treatment so that overdoses at that critical time can be reduced or avoided?
There needs to be better connections with community resources to continue care. Going into a treatment facility without a connection to someone who is well-versed in how to treat addiction in an evidence-based way and offer things like medication for addiction treatment, specifically, I, for example, treat with Suboxone in our clinic, leaves people vulnerable for exactly the same reason that I said before. There's a lot of connection that you need to have with behavioral health and with other folk in the community to make sure that all of your arms are wrapped around patients to secure stable transition, and for as long as it's necessary, right? Hopefully, in some way, shape, or form, you're gonna have support for the rest of your life. How much or how little depends on what you need, and that speaks to, increasing or decreasing the care according to how the patient is doing, as long as there is connection and communication, and it's happening in a bidirectional, open, and trustful way. That's so important. I would say that, the relationship you have with the person that is treating you is just as important as the relationship you have with your spiritual guide or your, other people in your life that are that important to you, because there's a lot of influence that is had, and your treatment path can take different it can be high-level care or low-level care depending on the connection you have with the provider. And I've seen where a mismatch of a patient with a provider actually does harm. And so if there is a question, if you don't understand, if your provider isn't giving you enough time, isn't giving you the answer that you need or you want to hear, switch your provider.
Mm-hmm. Peer support so recovery coaches is a very important tool that needs to be used more, especially at transition points. We in our team is heavily integrated with recovery support, because that, and Pete, you can speak to that, how important that is to help people to stay engaged in care, to have that person who has been there to help them navigate. There's this push for more beds, and we know specifically for opioid use disorder, this largely should be an illness that's treated in the outpatient setting. Again, everybody's individualized. Some people will need inpatient, but detoxification, taking people, detoxing them off, and then expecting the same outcome is not only dangerous, but it's fueling the crisis. Speaking to what Damien said, removing that tolerance and then expecting this long-standing illness to be treated without any other treatment. So that's where helping people at that point navigate into the right kind of care can be very helpful, and has been one of the big game changers in our treatment continuum.
Yeah, I get a lot of friends that are recovery coaches, but how do you guys feel, now that medically assisted is coming to the forefront, what about long-term treatment? Now it's almost like that push that we had a couple of years ago where everyone's trying to get more beds and longer term. Because to get 30 days is a miracle anyway, but to get more treatment facilities that will do longer than 30 days, 30, 90 months if need be. I understand it all comes down to, the money, but where do we stand on, why can't an opiate, a heroin addict, go into a treatment facility, get weaned down off of Suboxone, stay there for 2 or 3 months, and learn some coping mechanisms, try to get to the root of their problem, the issue that started this whole thing, or the issues that started this whole thing for them, and then they can, with the help of a 12-step fellowship, with the help of group therapy, with the help of individual therapy, get back on their feet. And, that was the only thing that ever gave me to show me the light, was being clean for 90 days. It was a 30-day program, then sober house, and, I realized that, I got a life. I can do this. I didn't stay clean, but I knew it was possible, so that there was a big push a couple of years ago, and then now with medically assisted, that's kind of gone by the wayside. Like, no, we don't need it now, and it's just I just didn't know how you guys felt.
None of those are mutually exclusive, and again, speaking to individual, we're all individuals. We all have competing priorities in our lives, different diagnoses that may contribute, different living situation, different stressors. So that's an important piece of it. There are people, I have many patients who we get into residential treatment and really need that level of care, and that's what worked for them. But in medicine, we're driven by data and science and outcomes. And what we know is the single most effective treatment we have to stabilize people at this point are opioid agonist treatments like Suboxone and methadone. And because over the past even 5 years, the whole landscape of this epidemic has changed with fentanyl. That, again, to Damien's point, one time for this relapsing illness could be lethal. So none of us are really willing to take that chance. Plus, it's a very risky thing to do, and it's really not based in evidence. That said, we have people who absolutely cannot stabilize in the outpatient setting, and they need that, and we send it. We just don't do the cookie cutter that everybody now needs to start at the top and step down. There are some people who do just fine with meeting with a peer support, and that's it. Again, it's you're very rare that you're able to do that, and it's amazing, and if people can do that, that's wonderful. There are some people that, and Suboxone, there are some people who need methadone, and a psychiatrist, and a therapist, and residential. So again, it depends on the person and how we individualize that, but we don't do this for any other illness in medicine where we say everybody needs exactly the same thing. So we're applying what we know about the illness and about human condition and the outcomes. And most people, we say, if this is working for you and you're doing well, continue on it, and don't beat yourself up that you need to, quote, taper off of this. Certainly if patients want to do that, we're going to meet them where they are and work toward that, keep them safe all along, but we're not going to say it's 6 months now, it's time to come off, because it's not based in anything that's a semblance of what we know.
Woody, do you have something you'd like to add?
Sure, yeah. And it's great to have this conversation, first off. I've been in recovery for 28 years, and I've watched the pendulum swing from one side to the other, and I wished that I had medication-assisted treatment 28 years ago. It was really tough. I had to really work hard to get into recovery. Had we had medication-assisted treatment back then, my brother would probably still be alive, and it's nothing more painful than losing my brother to this illness. And I think it's wonderful that we've identified it as an illness, and we know more about the disease of addiction and the comorbidity around substance use disorder. It's important that we know. So, but to your question, I created Right Turn as an extended care program where people can come come into a structured level of care on an outpatient basis after they've been stabilized. They can continue on medication-assisted treatment and receive the professional help that they need, the therapies, the education and the prevention, which is so important. And they can stay for a long time. We have our Thursday night artist group. We've had people who've been coming for 15 years. It's about having a community, about having a safe place. In the last year, Right Turn has kind of resurfaced as a trauma-enforced therapy safe place for people to receive trauma treatment along with substance use disorder. It's very important. But I think one thing that we do well is we put fun back in people's lives, and I would invite anyone here to come to Right Turn on Saturday nights. We have a clean and sober cafe. I saw that there was a quick shot of Tom Petty in the film. Where's the filmmaker? Where? Thank you. thank you for this. I had the privilege of touring with Tom Petty and recording with Tom Petty, and he was a dear friend and someone I got into a lot of trouble with, but that's another story. But really, what a great loss. The first Saturday of every month, we're doing a tribute to Tom Petty at Right Turn. This last weekend, the place was absolutely jam-packed. So I would invite anyone to come to Right Turn to join our Sober Cafe and watch people in recovery perform, maybe for the first time, and experience the joy of music. It's how do we offset, how do we make recovery fun is really, finding that kind of spiritual connection. It's a powerful thing. But to your point, let's give people a place to come, a community with a safe place for them to come together. And Pete, as someone in long-term recovery, you and I both know that 12-step recovery provides a longer outcome for long-term recovery. So that's important stuff to reinforce. We can't forget that,
Thank you. So please join me in thanking our panelists very much for giving us their time today and answering our questions.